I'm really privileged today to be with a close friend and a mentor. She is young in age, but very seasoned with her skill set and what she has done to the field. Dr. Megan Coylewright. She's a structural interventional cardiologist known for her research focus on heart teams and shared decision making. Dr. Coylewright is an editor of the American College of Cardiology, CardioSmart, which is all of us use for patient explaining procedures as well as disease state, and patient voice program, and an active volunteer with the Society of Cardiovascular Angiography and Intervention. Dr. Coylewright completed her medical school and residency and master public health training at Johns Hopkins and cardiovascular training at Mayo Clinic, and her home state is Minnesota. Dr. Coylewright experienced building structural programs and has published about this before. I recommend reading about this, and has reached from the Northeast to the Deep South with expertise in teams building alongside rapid clinical growth. She serves on the Executive Steering Committee for a global devices trial focused on TAVR, left atrial appendage occluder, which is we're going to talk about it in a second, and intra-arterial shunt, and leads research on optimizing heart team and shared decision-making implementation. Dr. Coylewright, again, I meet with her every meeting and I tap on her experience with every interview. I think I have so far with you maybe 5 or 6 interviews. I counted, who's counting? And I'm really looking forward for your presentation, Dr. Coylewright. And thanks for doing this for us.
Thank you so much for the invitation. I'm really excited to create a conversation around the use of ICE to support our structural heart interventions. And I think that focusing in on this is more important today than ever before. I'm in Washington, D.C. right now at an American College of Cardiology and Industry meeting, and we're talking about the future of structural heart. And we just learned about a day or two ago about some really proposed big cuts in reimbursement for left atrial appendage occlusion. Not sure if you heard about this, but it is going to be so important that we think critically about how to ensure that our procedures are efficient. Of course, they need to be safe and effective, and thank goodness the field of left atrial appendage occlusion has matured in such a way that we are able to minimize the tools that we use and still have excellent results. So this will be the frame around the conversation today, is thinking towards the future of medicine and how we can deliver the same excellent care, the care that's focused on patient preferences and goals, but also to be very efficient with our limited resources. So I am a structural interventionalist. I'm an ICE enthusiast, and I practice up in Duluth, Minnesota, my home state. And today we'll talk a little bit about an overview of ICE and structural heart procedures. We'll begin with patent foramen ovale closure, PFO closure. And this is a good place to begin if you are thinking about building your skills in ICE. We'll talk about the advantages of ICE for LAO. This is going to be the bulk of the presentation, but we'll also talk about the emerging role of ICE in tricuspid valve interventions, and then future perspectives and expanding applications. So throughout the presentation, I'll use this acronym of ICE for intracardiac echocardiography, and I really look forward to feedback on how people are using this. So let's just look at an overview of ICE. You know, the timeline is that ultrasound began really in the 60s, and we had early development of small probes, but it wasn't until really the 2000s that we started to think about using this in PFO and ASD closure. Really was more prominent in some of our adult congenital applications. And then in the mid 2010 to 2024, we saw an emergence of this in left atrial appendage closure. When I say emergence, a very small group of operators. We have not seen really an uptick in the broad utilization of ICE. And I'll talk about some of the reasons why and how you can work around that actually pretty quickly. We had then begun to see conversations around ICE utilized more in mitral and tricuspid interventions, although we still rely primarily on transcatheter, on TEE for that. We do have a recent state-of-the-art review that I would recommend that was published in JACC Cardiovascular Imaging in 2025. Now, this was focused specifically on the use of 3-dimensional intracardiac echocardiography. And I want to delineate the difference between 2D and 3D, and this will frame a little bit of our focus on efficiency. This from that important paper that Gilbert Tang led, talking about some of the potential applications of intracardiac echo And we can see a range of therapies from tricuspid tier to mitral tier, as well as annuloplasty, tricuspid valve replacement, congenital heart disease, and then left atrial appendage occlusion. This is an incredibly diverse group of structural heart procedures, ranging from relatively straightforward to incredibly complex. And we'll have PFO and ASD then be under that congenital heart disease, although PFO obviously is not a congenital heart condition, but is often utilized under ICE. But let's talk a little bit about which ICE catheter. There is a difference between 2D and 3D, but with regards to outcomes in left atrial appendage occlusion, not a difference in outcomes. So this study actually looked at the comparison between the use of 2D and 3D and saw the time for procedure was similar. There was excellent safety and seal in both. There was 100% technical success and no leaks more than 3 millimeters. Now, when measuring with 2D ICE, there was an undersizing of the LA by one size compared to pre-procedure TEE. And so one of the main differences between 2D and 3D is the ability for 3D imaging, which will give us adequate sizing. So in left atrial appendage occlusion, it is relevant to use 3D ICE if you have not done pre-procedure CT or TE. Recent guidelines from the Society of Cardiovascular Angiography and Interventions, or SCAI, highly recommends pre-procedural imaging prior to LAO. One of the main reasons is because we have more than one device, and choosing the device beforehand can help us get a best result, but also help us understand potentially what is the sophistication of imaging that is needed to be successful for the procedure. For many PFOs, ASDs even, and LAOs, you don't need very sophisticated imaging. The procedure is relatively straightforward. And so doing pre-procedure imaging can help us choose the tool and its expense that's needed to guide the intervention with the outcome that we're hoping to achieve. But it's really interesting that we do have outcomes comparing two imaging modalities in this space, very helpful to guide our decision-making. Now, we talked about the difference between 2D and 3D, but there are also different brands of catheters. Now, one of the very early developers of ICE catheters is Siemens, and you can see that they have a range of different types. They have 2D catheters, they have 3D catheters, and by the way, when we say 3D, we sometimes will say 3D or 4D, which 3D, 4D is really interchangeable, depends on some of the marketing. But the ability to do multiplanar reconstruction and 3D imaging is what we're discussing. So Siemens is definitely an option, as is the Philips VeriSight, and then New Vision is another option. So there's several out on the market currently that have 3D capabilities as well as 2D capabilities. And here's just a picture of one of the most often used 2D catheter, the AccuNav. I will show some recorded live cases throughout this presentation, and this is the catheter that I'm using in those live cases. And the nomenclature, when we're moving the ICE catheter in our hands, there's a few ways that you can move it. You can move the entire thing en bloc, so you can rotate it clockwise or counterclockwise. So when we're moving clockwise, we're moving to the back or posterior. When we're moving clockwise towards us, we're moving up towards the front of the body, anterior. So that's one way that you're able to move it. And rather than the whole knob itself, we'll often just pinch with the fingers right close to the sheath at the groin site, because it's tiny movements, really tiny movements with the ICE catheter. If we're going to be moving the entire handle, you'll see the ICE catheter swinging around. So very small movements. And then we can torque or tilt or flex anterior and posterior and right and left with the knobs that are shown there under C. Now, I showed you 3 different brands of catheters. They all have these same basic movements, but where the catheter torques anterior, posterior, and left and right is different. So some of them it's closer to the tip and some of it's further back where that part that moves is. And this is highly relevant for crossing the intraatrial septum to get into the left atrium for either left atrial appendage closure or mitral valve interventions. Some facilitate that crossing a little bit more. We'll talk about that. Why use ICE? We have TE imaging. We've grown up with it. It's really well established in the field. It's fun to have another friend in the cath lab when we're doing procedures. The decision-making is not all on us. We can weigh on someone else to help us decide, should we release that mitral clip, or how do we think that the closure of the left atrial appendage looks? But there are clear advantages to ICE. One of them is speed. And for anyone that works in the cath lab or the EP lab, we do want to move through these cases relatively quickly. That's part of being efficient. We want to use that room well and our staff well. There is much better imaging actually of the inferior septum with ICE, which is very important for left atrial appendage occlusion because we really like those inferior transeptal punctures. No difference in outcomes, but of course, hospital stay is often shorter. I'll have many people say, I send my patients home same day after TEE, but depending upon the level of anesthesia, the recovery can be a bit more difficult. The patient experience is definitely better. You don't have you're not intubated and you don't have a TE probe down the throat. None of that throat soreness, and we'll talk a little bit about the esophageal injury that can be seen. And then staffing. Who doesn't today have difficulties with securing the anesthesia and the TE imager that you need for your structural heart procedures? As we extend our mitral therapies and our tricuspid therapies, this is a very scarce resource. Let's just be honest. And so not having to have those additional physicians in the room is a huge benefit. I'm not talking about cost. I'm just talking about scheduling the procedure. But cost as well, if 2D is used, that is. The 3D catheters are much more expensive and mitigate some of the cost savings. But there are advantages of TE. For us as implanters, we get to come in after the pre-imaging's been done and, scrub out and start working on our reports, right soon after the procedure. It does ease the learning curve of a device implant by focusing only on one task. So I do recommend before introducing ICE that you get really good at the device under TE so you don't have to learn two things at once. Some people say there's improved visualization with TE. Let's just take PFO or LAO, for example. And I would argue this. I think there are a lot of cases where there's difficulty just because of body habitus with being able to see with TE, especially in LAO, in that really important 135 view. Sometimes it's hard to get that on TE. It is easier to clear the left atrial appendage of thrombus on the day of procedure, but we can talk about tricks for that. And some data, people say, well, in some of the registry data, maybe there was slightly more pericardial effusion with the use of ICE, but certainly there's not very many operators using ICE, and those that are using it are early in their learning curve, and it was a very subtle difference. But it is documented, so we could list that as an advantage of TE. So let's talk a little bit about some of the principles and technology behind ICE. So we've got the ultrasound probe in a catheter, and it goes through a very small sheath. So this is the 8 French AccuNav that I'm showing here in my hands, and that goes through a 9 or 10 French sheath. The Philips Vericide is a 10 French, so not a very large catheter, and it does provide very high resolution real-time images and perhaps could increase our accuracy and safety by the detail that's provided. I mean, it's really not even fair to compare ICE to TE in a lot of situations. I mean, our probe is right next to the anatomy, not trying to look through all sorts of structures. We'll talk about some of those barriers. So if you're thinking about beginning using ICE in your structural procedures, I would recommend to start with patent foramen ovale. It's probably a procedure you're very comfortable with. There is a less variability in that procedure, and it allows you a chance to begin to utilize your ICE skills. There has been studies comparing ICE and TE for PFO, and the benefits are really the same as for other therapies. It's quicker, it's less hazardous with regards to esophageal trauma, fast recovery, and in the PFO space, similar device-related outcomes. And I would argue, when you do ICE in PFO cases, it allows you to practice some of the early maneuvers that are needed on the left side. So one of the main ways that we cross the intraatrial septum is by looking at the wire across the septum and then doing some anterior flex. And if we want to clear pericardial fusion, it's the same anterior flex to cross the tricuspid valve and go into the right ventricle. So practicing that maneuver, very gentle maneuvers, and then looking through from the RV to the LV to clear for pericardial fusion is clinically relevant in PFO closure and will help you ensure that you have those hand skills to be able to think about more complex procedures. So here's some images to think about some of the differences between what you're used to for TEE. Of course, at the top of the imaging sector, which is right at the top of the screen, that is the right atrium as opposed to the left atrium in TEE, because as you know, the echocardiographic probe shows us whatever it's closest to. So in this case, the ICE catheter is sitting in the right atrium. And that thin layer of tissue that's jumping like a jumping rope is the intraatrial septum. And then you can see a Gore cardioform device in the left atrium being pulled towards the PFO. Now, when we're thinking about the images that we're seeing, we just identified the right atrium at the top, the intraatrial septum in the middle, and the left atrium close to the bottom of the screen. What's to the right? The superior vena cava, and to the left, the inferior vena cava. So we'll use some of those landmarks when we talk about transeptal puncture under ICE shortly. But here comes that Gore cardioform. We're pulling it against the intraatrial septum, and then now you can see it deployed, closing this PFO. Again, you can see as I rotate the ICE catheter to the right, you can see the superior vena cava opening up in this image. So here we have a still frame of fluoroscopy looking at that Gore cardioform PFO closure device and my ICE catheter looking directly at it. Similarly, we can see images using Amplatzer devices. And again, the right atrium at the top, and you can see that right atrial disc being deployed in this image. And I'll just say ViewMedi is a terrific resource for watching live taped procedures, discussing some of the uses, so I pulled that. So the reduction in need for general anesthesia and procedural sedation is very important, and avoidance of general anesthesia really helps us understand some of the benefits for that procedure. Excuse me for just 1 second.
Hold on, stand, please. Hi.
I'm just in the middle, I'm sorry. No, thank you. Sorry about that break. So I'd just like to transition over to left atrial appendage.
Coylewright, can I have a question for you? Since
please.
We're transitioning to, it is a nice transition point.
Yeah.
So part of the learning ICE, it has a very steep learning curve. As you showed before, we're completely reliant on a very expert, invasive echocardiographer who does the images for us. Look at the left, look at the right, puncture here, put the needle, right? Now, I'm running everything. So sometimes it's cumbersome for the interventionist to learn the images. So I don't know if they're going to cover it or not, but is there like a learning curve to learn the ICE, and how long it takes before somebody can be comfortable, starting with the PFO?
There is a learning curve. And to be very honest, I think your question is so smart, because many people have tried to bring ICE into their practice for left atrial appendage occlusion and become incredibly frustrated. And I think it's because we underestimate as proceduralists that ICE is itself a procedure. You know, we would not ever walk into a room having never done TAVR and say, I think I'll just wing it, see if I can put one of these valves in. But we do that with imaging. It's really interesting. We actually have, I serve as a proctor for ICE-guided left atrial appendage occlusion. And it's just a huge difference when you have someone coming to teach you during procedure. So if you don't have either someone at your institution that's familiar with ICE, you can contact the companies to bring in a physician proctor. I would suggest, you know, in general, we recommend in structural heart, if you're learning a new procedure, you learn from a physician that does the procedure rather than a clinical rep. And so I do think that that is the way to begin. There is some didactic that you can do beforehand. There are some simulators. All of that is helpful to a certain extent. But I think setting yourself up for success means beginning with simple procedures or beginning with a combination of ICE and TEE. And I'll talk about this in the left atrial appendage space. But let me share a little bit about how, when I proctor, what I recommend, and then you can start to think about it as I show you the skill sets in LAO. So let's say you did 5 PFO cases and you utilized ICE and began to just get a sense of the knobology. Then when you were going to more complex procedures, we really like to begin with a combination of TEE and ICE together. That way, there's no pressure on you. Let's say you begin a case and they're like, hey, there's a STEMI coming in 45 minutes. You're like, okay, now it's not the time for me to practice my ICE. I'm just going to do the Watchman or TE and move on. Or actually, one of the patients canceled. Now you have 2 hours ahead in front of you. So then you have the ability to break up the procedure into the different aspects. So I traditionally will say, on your first case, just do the transeptal puncture under ICE and then look with TEE to help you understand. And then do the rest of the Watchman or amulet procedure under TEE. In the next procedure, Then focus on crossing the interatrial septum with the ICE catheter. Do the transeptal with TE, just get through it, but then just spend that time. Do the rest of the LAO with TE. And then on the next one, do the implant. And the next one, the implant evaluation. And then slowly start to put it together. I think the reason why a lot of people give up on ICE-guided LAO is they try to do all of those things together. Even with TE on backup, everyone in the room is frustrated. It's hard to learn in front of your cath lab techs who see you as a master in so many other areas. But if you break it up into those different aspects, I think you can really build your success. And I'll give you some numbers at the end. How many do you need to do before you introduce ICE? How many combined? And then when are you ready to progress? And that's based on a lot of input from my learners. Did that answer your question to begin? And we'll dive in.
Absolutely.
Okay.
Yeah.
All right. And thank you for your patience with the interruption. I am staying at a hotel, and you can tell I'm excited. It's a nice one because they came down for the turn down service. So that's exciting. But thank you.
I thought housekeeping walk on me, not on you at work.
Yeah. So here's another example of where we're lucky that we have so much data. Sometimes people say, how are you going to move from TE to ICE guidance? This is kind of, you're just trying something new. It's off label. Actually, it's on label now. FDA has approved ICE for guidance of LAO based on a ton of research, including randomized trials. Some of them have been randomized ICE to TE. Larger ones have actually compared against a performance goal. But it was this ICE LAA study that I'm showing here that led to the final FDA approval for ICE guidance. That doesn't mean we can jump right into it without the skill sets, but it does mean that there is safety and efficacy data that utilizing 2D ICE, that's what was studied here, 2D ICE leads to favorable outcomes. So there are some back and forth discussions around when we should be doing ICE and when TE and what are the benefits. So we do recommend that pre-screening be done for anybody that's undergoing left atrial appendage closure. Again, it lets us choose the appropriate device and actually lets us pick the appropriate imaging modality. So we consider ICE if TE imaging is terrible, if we can't intubate for TE, and then if we have the ability and the familiarity and skill sets that we're able to move forward with the procedure. Ideally with ICE, because it's a little bit more difficult to rule out left atrial appendage thrombus before crossing the septum, we can talk about ways to do that. But for most early operators, they will not be able to go up into the pulmonary artery to look closely at the LAA. Uninterrupted anticoagulation within 4 weeks is a good idea of place to start. Certainly you can use ICE if you think you're going to need to use both imaging, or if you're unable to get TE. Truth is, part of the reason I became an early ICE adopter was just because of resource limitations. And that's where I think a lot of us are going to be heading. Volumes growing for LAO and our ability to access resources like TE operators that will stand there for an hour or two and anesthesia colleagues is really limited. So things to watch for include, vascular access issues. But again, a 10 French venous access, very rare when you're doing your punctures under ultrasound guidance, very rare. And then we think about with TE, if the patient has really a challenging anatomy, you're going to need ultimate images with TE and perhaps ICE as well. And then if you have good access to imaging operators and anesthesia, when I talk to people across the country, they don't have a desire to learn new skill sets if they've got all the resources that they need. It really limits the time they're in the procedure room, then they can pop out and do other things. That makes perfect sense to me. But then I also think about patient preference, which actually isn't on this list. When I talk to patients about their preferences, about being under general anesthesia, even if I tell them it's light anesthesia, being on a ventilator and having a TE probe down, we talk about some of the potential risks like gastrointestinal bleeding, the sore throats, and then the rare esophageal rupture. Unfortunately, I've seen esophageal trauma twice in my career that has been pretty severe. So it does occur, but it's not very common. So one of the first things people always ask me is, if I'm just doing ICE, how do I know if there's a thrombus there? Certainly, if you have pre-procedure imaging within 2 weeks, the previous slide said 4, but in general, when you're first starting, if you want to be more exact, the closer you have pre-procedure imaging. Occasionally I'll do TE in the morning, a quick screen in the prep area, and then I'll have them scheduled for ICE later in the day if there's difficulty coordinating that. Or if the patient has remained on OAC and you know they didn't have thrombus before, but we can clear from the pulmonary artery or from the left atrium the day of procedure. Let's move on to one of the hot topics when we think about utilizing intracardiac echo in the left atrium. Many of our early adopters gave up on ICE because of an inability to cross the intraatrial septum. And part of the reason is many of us are working today in single plane labs. Single plane labs are very deceiving as to where we are in three-dimensional space. So if you look down at the fluoroscopy, you can see my ICE catheter is very close to the wire that is coming up from the IVC through the right atrium, through the intraatrial septum, and out into the left atrium and then the pulmonary vein. But when I bend that ICE catheter and I look at the single plane X-ray, I can spend a long time thinking I'm next to the wire, but really if I were to swing over to REO, I see that I'm in a completely different plane. If you have biplane imaging in your lab, you'll see pretty quickly and could do X-ray guided. But we don't want to be on fluoro today. I mean, we want to limit fluoro as much as possible. So when I teach crossing the septum, I do teach that we're just going to watch on ultrasound. And I'm going to play this and there will be some audio, but I'll just show you what to watch for. So if you look at the ICE image, at the very top of the screen, you see a thin membrane, which is the intraatrial septum, and then you see a horizontal line, and that is my wire. And so the concept is we are going to do an anterior torque of the ICE catheter, and we're going to keep that wire at the top of the sector. And when we see that wire right at the top of the sector, that means that's where the nose of the ICE catheter is. And then we gently advance. And it really typically takes less than 30 seconds to cross. Once you know you're across because you'll see that big black blood pool of the left atrium come into view. So let's play this.
See on ICE, you'll see that you've got some signals. We're not quite in the right frame. There we are, close by. I'm going to focus in on the ICE image. Off fluoro for a second. Just following that wire.
So here, are you posterior flexing, Dr. Coylewright, to visualize the septum? So you are with the whole catheter, or you use the anterior posterior dial?
So when we are sitting in the right atrium,
it's easier just looking on the ICE rather than the.
When we're sitting in the right atrium and we're looking straight ahead and we see the wire, we are going to lean forward, which is an anterior torque, watching that wire in front of us. And then in terms of, so that is what I'm doing with my right hand, where I'm turning the knob, anterior torque. With my left hand, I'm pinching the catheter itself, and I'm clocking it and counterclocking it to keep that wire in view.
In view, okay.
So as long as we watch it at the top of the sector, we know the tip of our ICE catheter is right on that wire. And then we know that we've crossed when we see that. You can see here the left atrium in front of us. Now, an important caveat is that each of these ICE catheters has a different flexion point. Some of them it flexes from further back and some closer up. The 2D ICE catheter has a flex that really favors crossing the septum. The 3D catheters have a flex that's further back and makes it a little bit more challenging. It's true. But the concept of watching that wire on the ICE image or using biplane or both is the way to think about moving forward.
See on ICE.
What other questions do you have about that?
Yes, but usually, as you said, you are doing 2D, and usually you have, when you cross the septum, you have a bicaval view. So, and you have superior, inferior, anterior, posterior. But here you are depending on only going anterior. You are using the wire to guide you, right? Where the catheter we're going to be crossing, right?
Let's take a step back. So when we are doing the transeptal puncture, that's when we're using X-plane on TE. So that's because when we're doing a transeptal puncture, we are trying to understand where we are in space. We want to know if we're anterior or posterior, and superior and inferior. But once we find that point on the septum, then we do our transeptal puncture, put the wire across. Now we're talking about something a little bit different, where we've already got a marker on the septum. We don't need to know where we are in space. We can just look at it. That's where we're crossing. And so it does not require any X-plane or 3D or anything at this point. We just want to look for the wire that's already in existence. Now, when we do transeptal punctures on ice, we can use X-plane just like we do a TE, and many people who are transitioning feel more comfortable with that. But using a 3D catheter and X-planing through the septum, it is very hard to see that short axis aortic view. It is. It's hard to bring it out. And so when I'm doing a transeptal puncture under ice, I actually typically do it just with 2D. And the way that we know where we are in space is by looking at the far field. So I'll explain this with the image that's shown here. So at the top of the screen, you can see that very thin portion of the septum. And to the right up top is the SVC, and to the left is the IVC on the right atrial side. So you know top from bottom right away. You know what's high, you know what's low. And then when you look in the far field in the back, you see actually in this picture, the beginning of the mitral valve is shown. And if you look to the right, like at 5 o'clock, that's the left atrial appendage. So this is a relative anterior portion of the septum. In general, for LAO, I stick in inferior and mid to anterior for a lot of the anatomies. If we saw in the back of the shot there, the pulmonary veins, then we would know we were posterior. So you have all the information you need in one 2D picture to be able to tell where you are in space. So I'll play this one more time, and we'll just take a look at those far field structures to be able to see that point. Because you're asking a very important question. There's the mitral valve. And now I rotate posteriorly. We see the intraatrial septum. Here's my wire. And then we're looking back here. And we'll be able to see the left atrial appendage right down here, right by the mitral valve. Now we're watching that wire. And I'm anterior torquing here with my right hand while I'm just doing a little counterclock and clock and pushing. And here I didn't quite get across, and I came down, and now I'm in the left atrium. And that's about as quick as it is.
And as you said, this is, Dr. Coylewright, this is very small torques, very fine movement with the ice. Otherwise, you go completely off the field.
You just kind of swing around. Yeah, it's pretty subtle movements. And when you do your PFO closures with ice, you'll get a hang of that right away about how little movement is needed. One of the other things that people raise for the main concern about ice-guided LAO, besides crossing the septum, is are they going to have enough views to make a decision? Now remember, ice was approved for use in LAO by the FDA based on 2D ice data, showing safety and efficacy. So we've already proven it in studies. But now is the how. And one thing to remember is that the ice views are not directly translatable from TEE. We don't get 4 views that are the exact mimics, but we have some ways to kind of share with you how similar it is. So we have 3 views that we use with ice. One's called the aortic view, one's called the mitral view, and one's called the pulmonary artery view. So the aortic view is like a 45-degree view on TEE. Obviously, the aortic view shows the aortic valve in short axis. The mitral view is like a TE 90-degree view, and you can see the mitral valve in view. And typically that's when we're going into the left upper pulmonary vein. The aortic valve view is just the mid-LA. The PA view is the one that's a little bit more challenging to get, and I have a video to show you how to do that. That is the high angle, or the opposite of the high angle, which is low angle, the 135 TE. That's where you can see the pulmonary arteries in the lower left corner and the mitral valves in the top. And for LAO operators, that view is really what tells you the truth about your implant. Just like on TE, the 135 is what tells you the truth. So let me teach you a little bit about how to get to that. The selling point for 3D ice is really simply to not have to manipulate the catheter to get to the PA view. That's actually one of the main selling points. They do have 3D, so you can do sizing, but we do sizing before the case. And otherwise we can see for a leak assessment. So it's really about not having to manipulate. Once you learn it, it's not too difficult. So let's look at that. First of all, I'll just show you some examples of some ICE images. So here you can see the left atrial appendage, and we're doing measurements. And I show this slide just to remind you, I don't size on 2D ICE. I size before the case. And we also will check with fluoro. So here's an example of the mitral valve view. You see the mitral valve here. This is the left circumflex artery. This is the left superior pulmonary vein, the Coumadin ridge, and here is the left atrial appendage. This is a Watchman sheath coming in, and here you can see the beginning of Watchman deployment. We'll see the same thing on a live case, but I just wanted to show you on a still so you could kind of take in that anatomy. Any questions about that?
Beautifully illustrated.
Okay. And circumflex is a big marker for us in LAO because that's really where we want the device to land. So the first thing I'm going to show is just some basic toggling between the aortic valve view and the mitral valve view. Both of these views exist in the mid-left atrium. Now this actually looks like my image from before, so let me just double check.
Mid-left atrial view
There we
here. The left atrial appendage. There's the appendage right around 4 o'clock.
So this is the circumflex. We saw the appendage coming in and out. The mitral valve is here, and the left upper pulmonary vein is here. So this is the mid-left atrial view. And it's a little bit hard to see. Some of these fluoro images on this live case are stored fluoro, so they don't always relate to one another. So we'll keep that in mind. But also just take a second to look at our access. This is another common question. So we just have 2 venous access right next to each other, just like on a lot of EP procedures.
Mid-left atrial.
So now we'll take a look at this high angle view. It's a 135 mimic, but we call it the PA view because this is the pulmonary artery here. The mitral valve is up here. There's that circumflex, and here's the left atrial appendage with the Watchman sheath, quite deep in this picture. And this is a picture of what it looks like on fluoroscopy. And then I'll walk you through a little bit about how we get there. First of all, I just want to pause and show this good reference that's from Structural Heart that Jack Key saw was the senior author on that walks through some of the main positioning. And so one of the things that we're looking at here is thinking about some of these 45 and 135 mimics, which are a little bit different. So this, I'll walk you through and you can see my hands at the same time as we're moving the catheter to be able to show you how to get to this PA view. And I'll just say for the LAO operators in the room, don't you hate this kind of anatomy? This is some of the trickiest left atrial appendage anatomy. So in general, especially early on, this would be one you want to save for TEE. And so I think pre-procedure imaging is so helpful at early stages to set yourself up for success. So let's just walk through this one.
Really? And then going to do a posterior tilt. I can see we're trapped a little bit behind the sheath. And advance. A little more posterior tilt and lock it. And now I'm going to turn left-right tilt and advance a little more. We're waiting to see the mitral valve here. There we go. There's the mitral valve right at the top of the sector. Releasing a little leftward. I'm adding back more. Release a little bit of that posterior tilt. Just trying to see the os here of the appendage. Just a little bit of shadowing. Come back a little bit. See if that helps. A little bit maybe. Go ahead and store that on ice. Posteriorly.
So in that example, I'll just walk you through again. When we're looking at the left atrial appendage and we're getting ready for that PA view, we rotate the catheter posterior and look at the pulmonary veins in the back of the heart. And then we do a hard posterior tilt. It's like a back bend. You can see in this X-ray shown here, the catheter is bending down. Now we're going to look up at the left atrial appendage. With that hard posterior tilt on there, we then do a little left-right just to bring in the appendage. And then you're able to see the mitral valve, the left atrial appendage. Here it has a Watchman in it. The Coumadin ridge, the left upper pulmonary vein, and the pulmonary artery. So we call this the PA view, and it's a mimic of the 135. And this is really the selling point of the 3D catheters is that you're able to X-plane there. Still, it's difficult. The X-plane is difficult to see oftentimes. And then the circumflex is here.
There we go. There's the mitral. And so we're looking at the edge by the right-hand side of the device.
So on the fluoro, you see the deployment occurring there. It's a saved fluoro. So here you can see that we're able to measure the compression of the device. We can look for leak. And it does require, as you saw, some small adjustments as you go along. So there is a bit of a learning curve for that portion. Here. So these are the 3 views summarized. We've got the mitral valve view, the aortic valve view. Here's the short axis aortic valve. And then we've got this PA view here. And that's what allows us to understand if we've met past criteria, which is the positioning, the anchor of the device, the size by the compression, and the seal. Similarly for amulet for the close criteria. Here we are with our color on to look for leak. And those of you that are operators in the room might see an adjustment that needs to be made. Sure enough, that Nyquist limit needs to be down to 0.3. All right,
and usually the pass criteria will be able to get all these compression using ICE. Get all the compression, the sizing, everything will be perfect even after deployment.
Yes.
Interesting.
So Andy Goldswig and colleagues did put together a protocol. If you were early on and you wanted to understand how can I pick anatomy that won't be too challenging with ICE and set myself up for success. So I show this as a reference. I did want to just put in one more comment about something that's unique about utilizing ICE as opposed to TE. And that's a reminder that your patients are awake. Of course, you'll have them, sedated. My engineers love to watch the procedure, so they're wide awake and talking the whole time. But it does introduce a risk of air embolus from this unique aspect of the negative intrathoracic pressure. So if your patient's under general anesthesia, they're going to have positive pressure ventilation. But if they're awake, they can take a deep breath in, and that intrathoracic pressure can be low enough to draw air in if there's an open TUI. And it's not hard to get into the routines, but you do need to have a routine to limit that from happening. And so I'll just play, this is from a live case that is available on ViewMedi, which is a great resource of us chatting about that, and then we'll move on.
Resources are not abundant today in medicine. So I think we do have to be thoughtful about what are the complex cases where we need more advanced imaging.
So in your center, have you moved to conscious sedation? Not to try to eliminate Dr. Hayter completely, but do we need to do a general anesthesia for these cases?
We don't use general anesthesia. We use conscious sedation. And in fact, on the most recent live case we did, boy, our patient was wide awake because we wanted to be part of the show. So it depends on the patient about, in terms of their comfort, but it is just lidocaine at a venous site and it takes, as in your hands, probably a 30-minute case.
If that is 10 minutes. But I would say that the one thing to mention regarding that, if you're under conscious sedation, sheath management, critically important. All you need to do is have a TUI open or something, and a patient takes a deep breath in, and with negative pressure inspiration, the way God intended us all to breathe, not so great, right? So that you have to be really careful with sheath management.
It's such an important point, and that's why before we even get started on the case, we check a left atrial pressure to make sure that it's greater than 10 millimeters of mercury to help reduce the risk of any inadvertent air embolus. But everything has to be kept low, and we have to be very careful about that.
So one of the things that's very common when you introduce ICE-guided left atrial appendage occlusion under conscious sedation is that techs are used to holding catheters up high because they're used to arterial access. And so we really need to think about holding everything low, making sure the filling pressures of the patient are high. So I'll give them all 500 cc's of fluid before the case. And then being fastidious. Anytime you're pulling a wire out, you're ready to pull negative with the syringe. So those are some of the things with early proctoring that you can help set up some of the habits that are needed. And I'm just going to move past some of these so that we can make sure we have time. So an ICE versus TE summary, data support ICE-guided LAO with good pre-procedural planning and with making sure you have the experience. Perhaps with PFO closure first is a good place to start. And our available resources may necessitate that we use 2D ICE for many of our LAO cases, and we've got great data around that. We can anticipate that we have reduced GA and TA availability just because of the structural heart program's growth, and in addition to continued limited resources. And training is available. So I'm going to move forward here and talk briefly about the role of ICE in tricuspid valve. Before I do, did you have questions about what we've shared so far?
That's perfect. So just because there's a lot of audience interested in this, is there a proctoring program where we can tap into, like a proctor come to our lab to teach, or something we have like a program where we can go and do kind of back-to-back cases with somebody experienced like yourself?
Mm-hmm. There are opportunities for all of that. So through Boston Scientific, there is a learning program that we've designed called Ice Age, and it does start with a lot of didactics. Now, to be honest, when we first started doing the proctoring program, there were a lot of folks that kind of wanted to dabble. So when you ask your Boston Scientific rep to get involved in this training program, there is an online component. There is some learning to go through first, but it's very valuable. And once that is done, then you can move into having options to either go visit someone to watch cases. And I've had people do that, which they say is a great way of learning and plenty. Or you can have someone come to your institution. And so I think both of those can be very valuable options, because it's just, yeah, I'm sure many on the call have had proctors, and you know when they come, first of all, it's fun to have a new friend come to your institution or to travel. Like, you learn so many things even about other procedures. But usually it's just those 2 or 3 little pearls. They're very small, but they're enough to save you 2 hours of trying to cross a septum, or to really feel confident about releasing. You know, those are the things that you want to bring. So I think thinking about ICE as a procedure itself, not just as some added thing that can be done quickly. It really is a skill set. And so let's talk about those numbers. I mentioned that I would bring them up. I think that with regards to left atrial appendage occlusion, I would recommend that you are very comfortable with the device that you're using. So I would, let's say you do Watchman, I'd stick with Watchman, or you do Amulet, stick with Amulet. And I would recommend 50 cases, 50, under TE guidance. After about 30 cases, you think you've mastered it, and then you get a couple tough ones. So after that, then do about 20 combined cases and divide it up. The first time, just do the transeptal, then do the crossing, then do the implant, then do the assessment implant. Don't try to do it all at once. And by the end of that, you will be very, very confident to do almost, I would say 98% of your cases will be ICE guided, and maybe 2% you'll think either the patient is not able to lay flat due to severe anxiety or severe back pain or really horrible sleep apnea or severe obesity. There are reasons why it would not be ideal for them to be awake during the procedure, small number of people, or the anatomy is so difficult that you're going to want to have TE and ICE. Some lower numbers, I think, are possible with a proctor for sure. So let's talk very briefly.
Process, yeah.
Yeah, exactly. Let's talk very briefly about the role of ICE in tricuspid valve interventions. You know, there are limitations of TE. Those of you that are involved in tricuspid valve interventions, you know, we have a lot of limitations for being able to see, and then we have difficulty with the procedure. That's very painful for us as operators, for sure, and for not being able to get the result we're hoping for our patients. Tricuspid valve, it's anterior, it's to the right. There's a lot of maneuvers for TE. There can be limited acoustic windows and a lot of shadowing. A lot of our patients have mitral valves, prosthetic valves, or aortic prosthetic valves, or they could have intraatrial occluders or lopomatous septum. Even a prominent eustachian valve can get in the way. And the delivery system can get in the way. And then the leaflets are very thin, so they can be harder to see. So even though it is a TE-based procedure, there's a lot of reasons to think about the use of ICE as an adjunct to TE. But one of the difficulties with TE, you know, that we think about is the injuries. So this is actually a more recent publication, but there have been others that have shown injuries that come with structural heart interventions. So this is one that's focused specifically on tricuspid. And I think the more difficult the case, the longer the case, the more manipulation, the more at risk patients are. So I think utilizing ICE can perhaps limit some of that, you know, by taking all of the onus off of the TE operator to find those images. So I think it can potentially improve safety. And here, 2D is really not an option. The home view of ICE, which is where you're sitting in the right atrium, does not show you the grasping view that you need for tricuspid interventions. We really need to have that multiplanar reconstruction and the 3D imaging to be able to aid us in visualizing either for TEER or for valve replacement. And so this is a spot where 3D really shines. And so utilizing 3D in some of those other more basic procedures, it is true one of the benefits is being ready for the more complex tricuspid cases. So I would recommend utilizing it to become familiar with it in PFOs or LAOs for future use, but not for every case, as we've talked about. Here's some examples of some of the real-time multiplanar reconstruction that can be very helpful. This is with Evoke. And so let's talk about future perspectives. So we're going to have innovations, and ICE probes are smaller now, but they may actually get bigger. There's some new innovations that are looking at large ICE probes that will sit in the right atrium and perhaps be able to direct us across this without crossing the septum to be able to do LAO. There's all sorts of research that's going on. But we need, over time, even more clear, detailed visualization. The explaning through 3D ICE is still limited, and there will be improvements with regards to that, and safer devices that fit a range of anatomies. So just circling back to this recent article about 3D ICE, I think we've talked about a lot of these issues and how we really need to think about being efficient. We can choose the imaging catheter that is safe and effective, but also efficient and cost-saving for our patients. And I think that will be an increasing focus for us in our cath labs, all the while minimizing risk. I mean, TE does have risks associated with it. And so being able to minimize those will be a benefit to our patients. We really want to use only what we need in these circumstances. So in conclusion, I do think that ICE offers us safety and precision and efficiency, and that the future role of ICE is big. So I'm excited that those of you on the call tonight have joined, and happy to support your learning with questions going forward.
Coylewright, thank you so much for a phenomenal presentation about the role of ICE. This is really something up and coming. And I just want to reiterate, for the audience, please, if you have any question, use the Q&A box to ask any question to Dr. Coylewright. The anesthesia, the problem we're having right now is anesthesia and the backlog of cases. I see on the call, we have Heidi, our surgical and structural coordinator. We have at least 30 cases backlogged because of need of anesthesia and the OPRO. So what you just told us at the beginning in terms of learning ICE, expedite the procedure, expedite also septostomy, as well as maybe booking more cases that day without relying on anesthesia. This is really phenomenal and cost effective.
I think that is ultimately what gets us to change any of our longstanding habits. Necessity breeds innovation.
Yeah. So again, this is a kind of a tip of the iceberg presentation, just to show you the value of the ICE.
No
I know
pun
there
intended,
is a lot of there's a lot to learn, but again, Dr. Coylewright, if anybody interested, please reach out to me. I will give you her contact information, especially the email, in order to be for proctorship or any interest that down the line she come to you, or you can go to her. I'm going to be the first one to sign up. And I really thank you, Dr. Coylewright, for a valuable presentation. And maybe we can have you in a few months from now just to give us a more focused presentation on the tricuspid valve per se itself.
Yes, and I just want to emphasize that with regards to the proctoring, Boston Scientific has really invested in a fantastic program. And so starting with your rep and really showing that commitment by diving into that early didactics, that's the first way to get started. So I think all of you will have a way to really start to access those resources right away.
Absolutely. Dr. Coylewright, again, thank you so much for being with us. Thank you for everybody. This is exactly 7 o'clock. As we promised, we finish on time. This is Heart Trending coming to you every third Thursday. 1 CME accreditation. Everybody who signed up, we're going to receive 1 CME accredited from FACET. Thank you for FACET family for putting this together for really putting it together. And also, this is all recorded sessions. We're going to be hosted on the FACET website, and also going to be on the YouTube channel soon. Dr. Coylewright, again, thank you so much for your valuable time. I'm looking forward to see you soon.
Take care.
Thank you.